The NCEPOD Each and Every Need report was published in March 2018 and looks at the care of children, young people and young adults with the cerebral palsies as exemplar conditions of chronic neurodisability. The report is made up of clinical and national data, and today we're going to talk about some of the 35 recommendations within the report and the diverse needs of this population. What were the issues around identifying children, young people and young adults with cerebral palsy that we faced in the study?
Well, this was really a very big issue because we had to use episodes of inpatient care to identify the children and young people, because data simply isn't collected at the moment in outpatient settings. Hopefully in the future it will be, and there are drivers for that, like the community services data set. But at the moment that data isn't recorded and collected, so that was an immediate challenge. We then found that the accuracy of use of the term cerebral palsy was really a lot less good than we would have liked to have seen, and people were using cerebral palsy as almost like a bucket diagnosis, if you like, to put in anything that's physically disabling, rather than seeing it as a very precise diagnosis that's based on set criteria. And what we found when we were looking at what was actually written in case records about a person's diagnosis is there was really very limited information about the variation in tone. Was it spasticity or was it dystonia? And these things are really important because the tone variation informs the care of the patient, and there are nice guidance specifically written not only on the management of cerebral palsies but on spasticity management, for example. But if you haven't even recorded in the notes what the tone variation is, then you're not going to be able to accurately manage the patient subsequently. So
there were deficiencies, were there not, in description of actual levels of motor disability?
Yes, absolutely. So the gross motor function classification system has been around for well over 20 years. It's a really well validated way of describing the level of motor function of a child or young person with cerebral palsy. So the evidence isn't lacking in this area, and yet the translation of that evidence into clinical practice was really very poor indeed.
What about the wider needs of this population in terms of how well there was records or evidence that they were being met?
So whilst the reason for the acute admission was reasonably well documented in most cases, the wider needs of the child or young person, how they communicate, their level of learning ability, whether they needed special equipment to move around, we found was really poorly recorded. And some symptoms were not well managed. So a good example is pain. And again, this is an area where there is fabulous evidence from international studies that pain is a major determinant of participation and quality of life for children and young people with cerebral palsies. And yet what we found in our study is that routine inquiries about the presence of pain or not were really scanty. And even when pain was identified, the evidence was that it wasn't universally well managed at all. And another example is weight. It's a very basic thing. When anybody goes into hospital as a child or young person, they need to be weighed and measured. Weight is important because it underpins accurate calculation of doses, whether it be for antibiotics or botulinum toxin injections. And we were quite staggered that a third of children and young people had no weight recorded in their record at all. And that is a real cause for concern.
Why do you think that was?
So the reasons most often cited were that wards or facilities just didn't have the right equipment. So they didn't have wheelchair scales, they didn't have hoists, they didn't have the right slings in place. And so the weight simply wasn't recorded at all. And that, in this day and age, is just not good enough.
Yeah, one of the things we found that wasn't always available too was an emergency healthcare plan for some of these children and young people and young adults admitted acutely. Can you tell us what you feel should be in an emergency healthcare plan? And it does come out as one of the recommendations in the report too.
Yeah, so an emergency healthcare plan is simply a tool that follows the child or young person across settings that can be referred to in the event of a healthcare emergency. And it's a really good place to have basic information about the child or young person's health conditions, pointers about treatment, who to call, when, and so forth. Families tell us that they really value these tools because they get fed up of having to tell their story endlessly, and particularly in an emergency when you want the right people involved at the right time, and the right care delivered in a timely way. So there have been lots of recommendations made, including in recent college documents promoting the use of and creation of emergency healthcare plans. They're also a good place to record if there's going to be any variation from advanced life support. For example, in an extremely medically frail child or young person, it might not be appropriate or in tune with the person or their family's wishes to strive beyond the pale or to go to intensive care. So this document is a really good place to record all of that information in a way that is accessible and can be quickly referred to. So we thought that these would be an embedded part of practice, and indeed when we asked in the organisational questionnaires, organisations told us yes, we know what they are, and yes, we've got schemes in place to develop these. And yet when we looked with the reviewers into the weeds and into the detail of the notes, they were really very rare evidence, probably less than 1 in 10 case notes where such a plan could have been useful. Was there evidence of its existence at all? So Cathy, as a paediatric anaesthetist coming to this project, I wondered, were you surprised at the number of seriously ill disabled children and young people that we identified through the report?
Nearly a quarter of those that presented as an emergency were seriously ill by commonly used definitions. And as expected, quite a lot of those children, people, young adults, had very complex needs. 1 in 5 required long-term ventilation, for example, and had a lot of comorbidities. So this was not surprising. They didn't always get reviewed by senior clinicians rapidly after admission, and despite standards from the colleges that are well set now for many years. And so that was really quite worrying. That senior input could have made a big difference.
So Cathy, we both work predominantly with children and young people, but our reviewer team was much broader and included physicians and practitioners from the world of adult medicine. And the topic of transition is a really, really hot one across all agendas, and concerns about transition and families telling us they don't want to feel like they're falling off a cliff and how difficult that is. What did we learn about transition from each and every need?
Yeah. Well, during the time we were working on the report, if you recall, there was nice guidance came out on transition, and no surprise there, it is a really hot topic. What was really surprising, but it wasn't contrary to my experience, is that some young people were still being cared for into early adulthood by paediatricians, and that was because in the population we were looking at, there were no identifiable leads for neurodisability often in adult care. So patients were literally lost in transition. There's obviously a need for better leadership there, and there's a need, and recommendations in the report point to that. In fact, it's a key recommendation for joined up care with, where appropriate, social care and education, but also really importantly with primary care, and a need to plan transition, as is recommended by NICE, from 14. There were some easy wins, we felt, which are transferable to the care of all young people with both acute and chronic disease, for inclusion of them in discussions and in decision making. And sometimes there was very poor evidence of that, and particularly if young people were challenged also by having complex communication needs, which really didn't seem to be often well recorded, as we've said.
So Cathy, as an anaesthetist, you're obviously very interested in perioperative care, and I wondered if you wanted to say a little bit about what the study found in that regard.
We sampled deliberately to include a population of children, young people and young adults who'd had surgery or a procedure, because we know they're an important part of the inpatient population, particularly having things like orthopaedic procedures, major and minor, but also small procedures like change of gastrostomy tube or botulinum toxin. In general, the standard of care was pretty good for that group, and there were probably around 150 that had a general anaesthetic that we looked at, with good senior input and good care. We did find some evidence on occasion where multidisciplinary planning could have been much better though, for both minor and for major procedures, with better join up between anaesthetists, surgeons and paediatricians to improve the quality of care during the admission, including pain management on occasion. What was disappointing was sometimes we found that just as we were talking about around inclusion of young people, that the consent process might not have been followed as well as it should have been. So obviously important for discussions to involve the young person and their family, but when it comes to signatures on consent forms, then it's obviously inappropriate for parents to be signing consent forms once young people move into being over the age of 18 years old, and so that was of a worry to us. On an organisational level, we also saw that on some occasions, day procedure units said that they did have issues with admitting severely disabled patients to their units, and that's obviously contrary to national recommendations as well about improving access for all patients.
So in summary, each and every need really does matter and requires very careful and precise identification by an expert multidisciplinary team who are communicating well with the patient, with their family and with each other to make sure that care is delivered to the highest standard throughout. We believe that the Each and Every Need report recommendations can be implemented, very many of them, without the requirement for additional resources, and that things could be done a lot better in a more equitable way. We commend the report to you. Please read it with your teams, and even if you can just pick off one recommendation at a time and aim to make positive changes, then really you can be part of the movement to make a positive difference for disabled children and young people.